Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to another episode of Paw Patrol with your host, Dr. Jeff Dikis.
And Dr. Leland Jaffe.
Today we're joined by Dr. Ashley Dikis. How are you doing, Ashley?
I'm doing well, thank you.
So you
Excited
guys
to be here.
Yeah, thanks for joining us. You're kind of the pinch hitter, you know, when a guest falls through or we have to change plans on the fly. Like I come to you and you're like, oh, can I just not enjoy my Sunday? Can I just not have a nice afternoon?
Where else would you want to be on a Sunday afternoon, right?
I know, right? But talking about feet.
On a wedding anniversary, there's no better way, a romantic way to celebrate. How many years together?
12.
This is 12.
Oh, wow.
Yeah.
Good for you.
Mm-hmm. Yeah.
10 years is diamonds. 12 years you do a podcast together.
Yeah.
Okay. That's good. I like that.
Little did I know.
Said no woman ever, I'm sure. This is my gift. Take it back. So you guys just had commencement then, so at your respective schools. So how'd that go for you guys?
Yeah, how was yours?
It went really well. It was, when everything went off just fine. Nobody fell. I didn't knock anybody's hat off trying to hood them. All the graduates had their smiles on their faces, and it's just a really cool experience. I feel like as a, faculty member, just as a provider, it's kind of energizing, right? Like you're so excited to finally see this group kind of go across the stage, and it kind of reminds you of that excitement level, because you don't necessarily always carry that with you every day out into practice, but it's a good reminder.
I agree. I mean, there's a few of those really pinnacle moments throughout the year. Match day, certainly one of them, and then commencement as well too. But yeah, no, it was fun too. I did the hooding last year, not this year, and we have two people hood at the same time. And my first one I put on backwards. Not completely. I didn't put the hood in front of the graduate, but it was like flipped upside down, and I'm pretty sure it was choking him a little bit. But we got that straightened out pretty quickly.
It's not as easy as it looks. There is some skill involved with the whole process. Yeah.
Yeah. When we got invited to be doing the hooding, they sent us. It was like a 5-minute instructional video. Kind of made me nervous. Mm-hmm. It was pretty technical.
Yeah. The pressure's on.
That's right.
We got Ashley some new headphones, which are really just my hand-me-downs. I got some new cans, and so Ashley was fighting with her old AirPods that were like going in and out, losing connection, battery dying. So, and we got the upgraded light there. We're looking pretty good here. We're starting
kind of official.
It took 12, 13, 14 episodes, but we're starting to look a little bit official. We're starting to get it together. It took a while.
I think it's pretty legit.
Yeah, we're pulling it off, I think. I don't know. We'll see. So today, Ashley is joining us, and why don't you tell the people, they may have heard a previous episode, but maybe not. We're going to treat this episode more as like a featured guest like we do with the others, and kind of go through some cases and talk through some more technical aspects of some of the things that you do. But why don't you give the people kind of a rundown of your current position and how you got there?
Sure. So I am currently an assistant professor in the College of Podiatric Medicine and Surgery at Des Moines University. DMU is an all medical campus. So we have, variety of different programs on campus: osteopathic medicine, physical therapy, physician assistants. We now have an occupational therapy program, which I think is really cool too, and others. So yeah, it's a great working environment. I love being there. I'm biased because Jeff and I went to school there, so I certainly carry that with me as well. But love working in academia. That was always kind of the goal to end up, doing this. So, and then I also am the clinical department chair for the foot and ankle clinic at DMU. So I also help to oversee some of the goings on regarding patient care at our university clinic.
Sure. Do you coordinate any of the academic courses there?
I do. We all kind of share the load on that. So currently, I oversee our lower extremity dermatology course. So that'll be coming up in the fall. Do you? Yeah. We should share notes.
Love it.
So I think that's really, I don't know how you feel about it, Leland, but to me, I think that's one of the coolest parts of academia, right? Is that you kind of have like your hands in a lot of different kind of places. You're doing a lot of different things and keeps things exciting.
Yeah, I think, for me, coming from a private practice for about 4.5 years into academia, the professional development for me is much more exponential in terms of acquiring new skills. Being in the practice that I was in previously, I had no opportunity to do research, to really do a lot of public speaking, to do other types of things that helped me grow professionally. So, no, I completely agree. I think you and I met first. You were chairing the curricular guidelines for the medicine section is when you and I first met.
Yeah, that was an interesting project, wasn't it? Yeah.
It was fun though to put your stamp on really the nationwide curriculum and really what students are being taught. So I thought it was a fun experience.
It really was, and it was cool to get to meet via Zoom some of the other faculty from all of the schools were involved, and so that's how we kind of got to meet each other and then work with some of the other faculty from the other podiatric medical schools. It was really cool.
Yeah, so absolutely. Tell people what that means. So tell people kind of what you're talking about there. So you're helping standardize the national education across all of the podiatry schools, right?
Yeah, that's correct. So it's by the AACPM creates a curricular guide, and so this is supposed to be what are all the things that we think that by the time you leave podiatry school that you should master from a content area standpoint. So hopefully it's something too that national boards and things like that can look to know, hey, here are the things that we think are important that our students know as they're heading out. And heading into residency training.
Yeah, it's really helpful for students, but I think from a faculty standpoint, one of the first things I did when I came onto campus, the first course I actually took over was dermatology. So, and I completely rewrote the course, wrote all new lectures, all new content, and I literally sat down with the curricular guide and made sure that the learning objectives were the minimum that I had in my course to make sure I wasn't overlooking anything. So it is really a good blueprint, if you will, to faculty members to the bare minimum of what you need to have in your course.
Yeah, it creates that standardization, right, amongst all the different programs. So we all are covering that material. Mm-hmm.
Yeah, absolutely.
So before we go much further, Leland, show the people your T-shirt.
Yeah, got my
representing. Got some gear. Sent out the gear for you. We're representing. So yeah, my family members have been asking for some Paw Patrol gear, and I'm like, you don't even know what this is. Like, how's your podcast thing going? Like, fine, but you guys don't really know or appreciate really what's going on. But they want some gear, so I don't know.
Yeah, no, I was out in Chicago over the weekend, and I think I got some looks. I think we're catching some interest out there, so
what is this guy into? All right, Ashley, so back to you a little bit. So during fourth year, they had the opportunity for an administrative month where you spent a month with Dr. Yoho, the previous dean, the current dean at the time when you were a student. So obviously that kind of infers that you had some idea on academia. So what kind of things did you see during that month that kind of reinforced your thought that you did want to go into academics?
Yeah, that was a really cool experience. And I don't know that it's a rotation that a lot of students instantly think of as an option that they're going to choose to spend a month during their fourth year. But it was actually my very last rotation right before graduation. And it was really cool because I don't think you appreciate until you're on this side of things, meaning like on this side of academia, just what all goes on behind the scenes. And certainly I wasn't able to attend, all of the kind of meetings that the dean, would go to, but I helped out with, the interview process for new, applicants for the program. And I had to give a lecture to students in one of the courses as like part of my kind of experience. So it was this little kind of teaser of what life as a faculty member or the dean might look like. So yeah, it was definitely lots of meetings. He has a lot of things that they have to kind of help oversee, but meeting with students if any issues came up, and just kind of really having a better appreciation for what all the administrative side of things really looks like. Because that's a great experience. Be pretty intense. Yeah, it was really cool.
Yeah, because I think a lot of students assume we're coming up on summer now, and they're like, have a great, summer, a few weeks.
Yeah.
I'm like, I don't get any time off.
No.
I wish.
It would be awesome. Yeah.
How do I get a summer break?
There are like lulls, there are certain times of the year where things will kind of slow down a little bit. But sometimes, if anything, I find it's like, okay, good. I've got time to catch up on some of those other things I haven't been able to work on. So there's always something to do. Always.
So you went to Purdue University and grew up in Indiana, where everyone calls a soda pop a Coke. Can you defend your people in any way of how that makes any sense?
Well, I don't want to speak on behalf of everyone in the state of Indiana, because I certainly think there are things that are regional, even within states and areas, right? But it was not uncommon to say that you're going to have a Coke, and Coke was just like another term for, you're going to have a soda or a pop or whichever other term you choose to use. But either way, you get the point across, right? That's
always blown my mind. That's always blown my mind as like that. Who thought of this? This just is not. All right, moving on. To
me though, it makes more sense than saying pop. I mean, I grew up in Missouri, and we called it soda. Chicago, everyone calls it pop, and to me, pop is just a noise. So I think this might be another good poll to put out there for the audience to vote on.
I think you should. Please do.
A pop
talk about a controversy. This is a serious one.
This is a serious one.
A pop is what your Achilles does.
That's right. Right. Noise.
You mean the drink or the significant injury?
Yeah. So have you guys been keeping up with Caitlin Clark? I watched them, the Fever play the Sky last night.
Yeah, that was intense, wasn't it? Like, they are not holding back. They are trying to get in her head any way possible. They're trying to rough her up. They're trying to, I don't know, man. It's a little overboard, I think. I mean, they're trying to like welcome her with not open arms, trying to say like, this is the big time. And I get it. It happens in the NFL. That happens in the NBA. Nobody bats an eye when it happens in either of those sports. And then it kind of gets treated a little differently in the WNBA, I think. But yeah, it's been fun to watch. I mean, they're not terribly good. That's why teams get the number one pick 2 years in a row, because they're not very good. So it's hard to expect any one player. Like Michael Jordan doesn't hop on the Bulls and start winning championships. That took like, almost 10 years? Nah, 7 years or something like that. So it takes time.
Yeah, no, absolutely. But it's definitely intriguing to watch. I've been enjoying it this year. And I full disclosure, was not a WNBA fan before this year, but I find these games intriguing and fun.
Yeah, I 100% agree. I'm like yelling at the screen. I'm like, what am I doing? I'm watching WNBA. All of a sudden, I'm all in, and like I care. I know who the players are. Never before this year have I cared. So, what she's doing for that sport is unbelievable.
Yeah,
I think just women's sports in general. I mean, I've been following women's volleyball at the collegiate level, which was amazing this year. Women's basketball is amazing this year. So it's awesome to see.
And the Olympics, that always shines a brighter light on women's sports like gymnastics and swimming, because we have some of the best in the world. So the Olympics coming up are going to kind of to use the analogy of the Olympics, going to pass the torch or going to continue the torch forward with women's sports. So
Nice. Agreed.
Yeah, it's exciting.
all right, let's jump into some cases here that you have done recently. See if it works. Yes. All right, why don't you talk us through, because there are people that are just listening, and we'll kind of paint a little visual picture for them as we go.
Yeah, so picture terrible arthritis of an ankle, and just picture that in your mind, and that's what we're looking at here. We've got a kind of little mild varus deformity as well. So just, kind of more end stage arthritis in this ankle. This patient, just super nice lady. I ended up seeing her actually because she was had some abnormalities on some labs, and they had diagnosed her with monoclonal gammopathy of unknown significance, and had done screening x-rays. They do full body x-ray, trying to make sure that they're not seeing any evidence of multiple myeloma or other potential underlying causes. Didn't see anything except there was some abnormality in this ankle. And so that's how she kind of ended up my way. She does recall that she had an ankle fracture probably like 5 or 6 years prior. Had some pain, and that had been managed non-operatively.
So there is an autoimmune component to this, which I think we'll see here in a second is why it's kind of interesting. So we're going to switch to the lateral. You still see joint space narrowing, especially posteriorly, with large osteophyte production anteriorly. They had enlargement of the posterior talar process. And then why don't you describe what we're seeing at the posterior aspect of the distal tibia that's unusual?
Yeah, so posterior to that distal tibia, there is, what appears to be like kind of calcification for those, again, who are listening, within the soft tissue at that location. And kind of at the more distal aspect, it has, a pretty kind of narrow zone of transition. You can kind of clearly see those, more well-defined margins. And then as you move kind of more proximally, becomes a little bit more fuzzy and not kind of as clearly defined at that location. She was not having any pain there. She was having quite a bit of pain in the ankle itself, but that wasn't even tender at that location. On advanced imaging, so I ultimately ended up getting an MRI just to take a closer look and really see kind of what that soft tissue calcifications were all about. And then on the MRI, it actually showed that is some bony formation that's kind of running along the tarsal tunnel. So that's all kind of like on that medial side, kind of sitting in the soft tissue at that location as well.
Generically, we would call that heterotopic ossification. Just we don't really know how or why yet, but if you're describing that, what you see, heterotopic ossification is just bone where it shouldn't be. Despite the significance of the horrible bone around the ankle, a lot of that can be normal. These osteophyte production here at the anterior aspect of the ankle up here, that could be normal. Enlargement of the posterior talar process, that could be fine, normal. But this large growth here at the posterior aspect would be heterotopic ossification. So you said that she ended up getting some advanced imaging, like whole body scan, right, to try to figure out what this is, or if it was something more serious, like malignancy.
Right. They did full body x-rays. They do like a full skeletal imaging. And that's when they found this little spot here. So they were looking for multiple myeloma or something else related to the monoclonal gammopathy, but ended up finding this, and that's where she got, referred to our office.
So I did a little research after you sent me this case and saw that there is. So I looked kind of deeply into heterotopic ossification, trying to do a little more research. I'm not that familiar with it. It was kind of a meta-analysis or an overarching study that talked about HO. Just keep calling it HO. It's shorter. So HO has a pretty strong correlation with autoimmune disease, neurogenic causes. So they went in and they had a bunch of animal models, and they would induce neurologic injury. And the worse the neurological injury in association with trauma, the higher the likelihood of heterotopic ossification. So they were theorizing that there's a neurological component, but then completely separate from the neurological component, sometimes just inducement of trauma caused this. It could be in this lady, or inducement of trauma with an autoimmune component would tend to increase interleukin 6, 10, and tumor necrosis factor alpha in those patients and lead to a higher incidence of heterotopic ossification. So it's not well understood of exactly what causes it, because I think it's multifactorial. At least that's what they were saying in the article.
That's what I was just going to say.
Yeah, there's lots of potential causes. So for this lady, I guess it makes sense that history of fracture plus or minus autoimmune component probably increased the likelihood for her, rather than having, because the concern is that when you see that would be osteosarcoma. When you see something that shouldn't be there, you always want to dig deeper and figure out, okay, is this nothing or is this something? Because, podiatrists, we hear stories all the time about how we get an x-ray and we discover this, or we see an unusual skin lesion and we biopsy and we discover this, that, or the other. So, this would be an opportunity to, not just ignore it and say, oh yeah, the ankle is messed up, but kind of dig a little deeper, make sure at least someone else is working them up from a global systemic standpoint.
And that's really where I decided to get the MRI to take a closer look and kind of see if we could help to kind of differentiate, what's going on here. And you're right. I think for foot and ankle standpoint, when we think about heterotopic ossification, there's certainly some literature showing following total ankle replacement. For lower extremity, most of what I think where we see heterotopic ossifications a lot around after hip procedures, and certainly kind of those large joint procedures. But from foot and ankle, I certainly think can battle it after total ankle replacement.
So one interesting component of the study that I was just talking about that looked at other studies that were looking into heterotopic ossification was, again, on an animal model, this time in a rabbit. They did two different surgeries. They created a fracture, and then one, they fixed it kind of minimally invasive and small incision with very little trauma, and on the other, they essentially tried to do a sloppy job with a large incision. They clamped it really hard. They included some muscle tissue when they clamped it, and they saw a significant increase in heterotopic ossification, just with equal underlying factors, but just the nature of that, how you perform the surgery and how kind of traumatic your surgery was, increased the likelihood of heterotopic ossification. I found that interesting. So what'd you end up doing with this patient?
So she had, at that point, she was having significant pain. She got really good relief with intraarticular steroid injection. She had been wearing a custom AFO to try and kind of just help her get around. She was seeing quite a bit of relief with that, but still, having pain. She had almost no motion because that ankle, with all the osteophyte formation and just the narrowing at that joint. But she wanted to make sure, what are my options? Am I a candidate for total ankle replacement? Went and sent her to one of my colleagues in town to be evaluated for that, determined she was not a good candidate. And so she did ultimately decide to move forward with an ankle fusion. Her goal was to be able to head out from her house and do some kind of short distance walking on a trail. And that was really her goal, to be able to do that and just kind of get around day to day with decreased pain.
With this type of case, I think it's a topic we talk a lot about, TAR versus fusion. What do you think in her case made her not a good candidate for replacement?
So part of it, she does have a high BMI.
Okay.
She also has type 2 diabetes. She does not have evidence of peripheral neuropathy, and she's really well controlled. But that was also a component of it. To me, again, when I think that the indications for TAR are kind of creeping, in the sense that for a lot of people, that's a much wider net of folks who kind of fall into that category. She also, if she'd already had a decent level of maybe some residual motion, but she'd had really little motion for a very long time. So I just don't think that for her, between she's on the lower end, I think, from an age standpoint, from my perspective. she kind of with her goals, her minimal motion at baseline, and with some of those other factors, like I said, the high BMI, some renal disease, and the type 2 diabetes. I think those are things that made her a better candidate for fusion.
So I want to go back for a second and talk about the steroid injection. So I think steroid injection, someone might look at that x-ray and say, like, what good's a steroid injection going to do? In my mind, a steroid injection is I tell the patients that it's therapeutic, potentially, but therapeutic and diagnostic. It may or may not help you. I've put steroid injection into an ankle that looks horrendous, and they get like 9 months of relief, and they don't want surgery, and they just keep coming in for steroid. I'm just like, I don't know how that's helping you, but for some reason it is, even though your x-ray looks horrendous. So it may be therapeutic, but it's also diagnostic, because sometimes you get fooled a little bit and you're trying to figure out, okay, is this all ankle? Are they having some compensatory changes at the subtalar joint because their ankle has locked up, that their ankle or talonavicular joint are having to compensate for the loss of motion there? And if you're going to stick an injection into the ankle and they obtain complete relief, that tells me, okay, I don't necessarily need to worry about those other joints, at least right now. I could focus on doing an isolated ankle joint fusion and have a high positive likelihood of success. So I think that's something not to gloss over, but the steroid injection, therapeutic and diagnostic, that helps guide your treatment. So what do you use? I use Kenalog, 40 milligrams. What do you use?
Yeah, same from my perspective.
Yeah, I put a little Decadron in there with it, but similar. I think another good point you made with this are really two points I'll highlight. Number one is talking about the goals with your patient, because I think, I'm especially with elective type surgery, I'm very transparent with the patients in terms of what are our goals, if we can, what are we looking to achieve together. I think that's something really important. And then number two, and what you mentioned, is failure to respond to high quality non-surgical care, right? So, you're mentioning the injections, the AFOs, those braces, and still being able to demonstrate some type of disability really helps to support the decision to go into a major, reconstructive surgical procedure. So I think those are really important things to make sure that are documented, and you go through that process.
I think that it is, I think for me, part of that goals conversation comes up for the decisions, for what kind of surgical procedure we're looking at, or decisions to have surgery at all. If somebody's, if we don't feel like surgery is really going to be able to get them a lot of benefit beyond what they're already experiencing with the non-operative, options, then you also have to weigh that as well. And I think surgery like this is risky, right? I mean, even if she's, wouldn't be a good candidate for total ankle replacement, still, this is certainly the type of surgery that if things didn't go well, she could end up with, a bad infection and even an amputation. I mean, there's risk involved, no matter what. So I think, like you mentioned, kind of being on the same page with your patient, having really kind of open conversations about all of the pros and cons and what we're all hoping to gain from it is important.
Yeah, and from a medical legal standpoint too, I think this far into my career now, especially with elective surgery, I'm really, really careful with documenting disability due to their condition. Right. The worst thing you can do is have somebody that you don't document these things, and then all of a sudden they come in and post-surgical, they can't run, walk, do yoga, go to work, and you're like, whoa, you couldn't do that before.
Right.
The surgery didn't help you, but I didn't cause this disability, right? So it's really important to make sure that gets documented preoperatively, just so no one comes back and points fingers. That's
a great point.
Yeah, I think that's a good point as well. Let's talk about your construct a little bit here. So for the people listening, you've done an anterior approach. So for an ankle joint fusion, you can do, there's a few different approaches. You can do a lateral fibular takedown. You can do an anterior approach. You can do kind of an arthroscopic ankle joint fusion with some cannulated screws. So I like this approach as well, either an arthroscopic or this. But when the ankle joint is so significantly arthritic, you have those huge osteophytes on the front of the ankle. I find that I struggle more so with the arthroscopic approach when there's so much narrow into the joint and there's huge osteophytes anteriorly. So the benefit of this anterior plate is that it's a big, beefy, thick plate, which is good. You want a strong construct, but it sits down perfectly at the anterior ankle at the dorsal talus, right where you had to take off those osteophytes anyway. So you take out all those osteophytes and you kind of cut out a spot for this plate to sit, and it usually nestles down really well right into that spot. So even though it's a huge thick plate, you're holding it in your hand, you're like, this is not going to fit in there. By the time you shave the distal tibia anteriorly and the dorsal talar neck, that thing sits down really well on bone. And then it looks like you have some crossing. Well, you have the compression component in the plate. So you insert your screws distally, then you do your compression through the plate, and then you fill proximally. But you also have a crossing screw there. So I like that construct. What are your thoughts on why you picked that?
Yeah, I mean, I agree. I think for her, I felt like that, anterior plate is really robust. And and especially I think over time, those plates have just gotten better and better. They're more low profile without losing that kind of strength that you're looking for. So I think you're seeing a lot less irritation, kind of long-term from the hardware anteriorly. They really do kind of sit nicely there. And as far as that screw from that kind of medial side down into the talus, the kind of goal and what I'm looking at there is, can I get that screw somewhere either kind of in the central aspect, which is really kind of where we ended up, or kind of more towards the posterior aspect, make sure we're getting some compression across that posterior aspect of the joint as well, because most of the other hardware is more kind of focused on that anterior half of the ankle joint. So I thought it was a good option for her.
I agree. I think these plates too also help you keep the foot in a nice neutral position.
Definitely.
Worrying about translation of the talus or plantar flexion. So I think that's a good choice. And, like a diabetic, obese patient, it seems like the right choice to use a plate as opposed to just percutaneous screws.
Yep, I agree. Looks good. Was it a great success? Did she love it?
Great success.
She's done really well. Yeah, luckily she did great. I actually just saw her not too long ago. This has been, I think, 2 years ago now that she had that done, and she needs to have the other side done. She's not excited to go through the postoperative recovery, but she did really well. She is one that I did check her vitamin D preoperatively again, just kind of knowing her history, wanting to make sure she was as optimized as possible. And she was low, and we treated her and got her into a really good normal range. And I think, luckily this is one that she did well, all things
considered. Do you use any therapeutic braces or orthotics or anything postoperatively with fusions?
I do have patients, I tell people, like, don't throw away that AFO. Sometimes those, I think, even can be, depending upon the deformity, right? Sometimes you can even still kind of utilize those with some modifications. But initially for her, she actually wore just an ankle brace, just like an off-the-shelf brace for a little while after she came out of her cam boot. She does use orthotics, just because she does have, quite a flat foot deformity as well. But I don't necessarily always kind of put people back. You're thinking more like from just like a protective measure as you're kind of transitioning out. I don't always put people into a brace. What's your kind of approach with those?
Yeah, I think per patient really depends. But I definitely would prep them beforehand that this is something likely we might need. If not, great, but just anticipate something.
I hate when people come back and ask me to do their other side. I should be honored. I should be like, wow, I'm so happy that you're happy. But now all the pressure is on. Because that first one went so smoothly. They're so happy. Now it's like, well, do it again. You're like, well, okay, but who knows? Non-union, plates breaking, like all bets are off. I hate that.
I think that's better than if somebody had, let's say, a bunion fixed elsewhere and they did, I don't know, a scarf, and you don't do those. And they're like, oh, I love it. Can you do that to my other side? I'm like, oh.
You're like, absolutely not.
No offense to the scarf surgeons out there, but
mostly because you don't want me doing a scarf. Go find that guy. He's good at scarves. I'm not.
Yeah.
Exactly.
Yeah.
I had a lady one time, I did a first MPJ fusion on her left foot, went so perfect. She came back, I did her right side, and she was so excited that she walked on it early and broke her plate on the second one. Because the first one went so well. She was ambulatory early. On the second one, maybe a little too early. And
That's a hard
of
thing to
course,
break.
Yeah.
yeah, she tried hard, I guess. Or I did something wrong, who knows. But the point being, you think, oh, this one will go just as smooth as the first one, and maybe yes, maybe no. So, oh man, I love it and I hate it when they come back for the second time.
Mm-hmm.
All right, let's jump into another case here. So, why don't you talk us through this one?
So this is a patient actually with that does not have diabetes. I see that there.
Yeah.
But that is, he actually has idiopathic peripheral neuropathy. And to me, this is an interesting one. He's a really kind of big, tall guy and had been dealing with a plantar medial midfoot ulceration for like 3 years before I saw him. So he'd had this deformity, was pretty long standing. And it's not even necessarily, I don't know if this is necessarily even true Charcot for him. When I see him, he doesn't have, are you going to the lateral there? He doesn't have a ton of that kind of like true evidence that would make me think that he's had like fragmentation and breakdown, like the morphology of most of those midfoot, structures is relatively okay. Certainly got some arthritis there. So whether this is kind of more of a progressive neuropathic flat foot versus, a true Charcot event. He doesn't necessarily recall because I kind of, quizzing him on, does he remember having his foot, be kind of hot, swollen, any of those types of things? Was he treated for that?
That's an interesting thought because when you sent me these x-rays and you kind of told me the story a little bit, I just assumed that he had diabetes and I assumed it was Charcot. But that's an interesting thought you bring up because if it's neuropathic, you can still, regardless of whether you have diabetes or not, if it's neuropathic, we can call it a Charcot event. But you're right. It doesn't have that kind of like blown out like a little grenade went off in the middle of the foot where all the bone is just kind of destroyed that you commonly do see. So it'd be interesting to think about the difference between an acute Charcot event with that kind of collapse and then the eventual coalescence of the bone in there versus like a slow neuropathic developing arthritic change. I mean, the end result is that the middle of the foot is just like plopped down on the floor and they have a wound and they're high risk for amputation, high risk for complication. Maybe it doesn't really matter, but it's an interesting thing to think about. What do you think, Leland?
Yeah, no, I agree. I think I'm looking at the rear foot. The rear foot's relatively preserved. There's still a small calcaneal inclination. Ankle joint looks pretty good. What caught my eye though is just the soft tissue envelope too is so profound. I don't know if it's like a lymphedema or if it's just a obese patient or both.
Yeah, definitely that lymphedema history for him. Yeah, you can appreciate it for sure. On the x-ray.
I'm going to teach my kids to use that insult on the playground. You have a profound soft tissue envelope.
Jeffrey.
That's my PC way of putting it. No, but I have a couple of people like this as well too that I'm currently taking care of, and discussing. We've all dissected through those limbs that just have 5 centimeters of soft tissue between the skin and the bone, and it's such a challenging case. I think that really does need to be considered in terms of how if you're going to do reconstruction on this. The soft tissue envelope is going to be a problem.
Yeah, and I think I did this again. This has probably been about a year ago. Now that he had his surgery done, but more and more as the kind of MIS burrs are being utilized. I think he could have been somebody that I, especially given the fact that his deformities maybe not quite as severe. Some of the others that we see with some of the Charcot, true rocker bottom type foot, where you really are going to have to do a lot of osseous work, some joint prep, utilizing an MIS burr, especially in these patients where you're a little bit more concerned with the soft tissue envelope, I think is interesting. I haven't tried the MIS burrs for that indication yet, but I know they're being utilized quite a bit for joint prep in Charcot reconstruction.
So was this? Go ahead, Leland.
No, I was going to say a little shout out to UPMC, but some of the literature that I quote too is in terms of predicting ulceration and that Meary's angle, cuboid height. I know some of that was published out of, I think, your institution, right?
Yeah, Dr. Wukic looked at that quite a bit, I think. So I think Is this one where that is just his body habitus, or is this one where it looks like you could almost squeeze with proper compression wraps? You could squeeze a lot of what I see there out of there, like lymphedema. I've seen these feet where that forefoot is so edematous that you get them into some wraps and you can get a lot of that fluid out of there pre-surgical. Or is this just he's a big guy?
I mean, he is certainly a really big tall guy, but definitely he's battled venous stasis ulcerations, and it has been treated by the vascular surgery team in the past.
So what was your plan for this before we jump ahead to the post-op? So what's your thinking here? Because we have, for the people just listening, we have some kind of, on the AP, we have a little bit of talar head uncovering with some lateral forefoot abduction. We have degenerative changes, mostly at the midfoot, TMT, navicular-cuneiform joint. But aside from the talar head uncovering, the talar-navicular joint looks kind of okay. Subtalar joint is a little hard to evaluate, but the ankle joint remains pretty well aligned. So what are your thought processes here for how to reconstruct this?
Well, again, from his standpoint, he had been in an AFO, had been in offloading devices, had been getting, wound care routinely, and just wasn't really able to see much change. The ulceration was really healthy, and he had gotten down to a point with some total contact casting to where the ulcer was really small, had never actually had any issues from an infection standpoint. Surprisingly, he really gotten lucky given the chronicity of the wound. Had a bone biopsy that was negative prior to going down the road of reconstruction. Because I think, again, if you have something that's open for that long, from my perspective, even without him really recalling or having had previous evidence of, an episode where there was concern for infection, I mean, I think that that's something that needs to be ruled out before you're going to consider putting internal fixation in this patient. So
how do you do your bone biopsy? Are you doing that in the office? Are you doing that in the OR? Are you using a needle? Are you doing just a rongeur of a chunk? What are you doing?
So to me, it depends on the kind of how neuropathic, how profoundly neuropathic the patient is. I have had some that I've used a GM sheeting needle or even a rongeur in the office to obtain a sample, always going away, outside of the ulceration, if at all possible, not going through the wound to avoid any, contaminant from that location. But a lot of times these are, in the OR with the GM sheeting typically.
I do a lot of them in clinic too with the GM sheeting needle.
Yeah.
Good. I think that's a good technique to know, because I think that is a relatively quick, necessary thing to kind of rule out underlying osseous, osteomyelitis before you implant hardware, because you'd rather know beforehand than after you've implanted all the hardware and turns into a big rotten mess where you're pulling hardware back out. You'd rather take that little step ahead of time to know. So your idea here is to reconstruct the medial arch, kind of lift up the navicular cuneiform, TMT, reestablish some talar head uncovering, correct that. And so what are your thought processes for what you could have used? We'll see here in a second what you did use, but what's your thought process of why you did what you did?
So for him, I think kind of from a rear foot standpoint, I'm going to look and see he had a calcaneoaxial done as well, and his hind foot was in good alignment. So I knew that there wasn't, a lot that needed to be done from a positional correction standpoint of the hind foot. But I do think that talus is a lot of times really driving that talar position, these midfoot deformities. And I've been burned in the past, especially when I first got out, of trying to simply just address the area of, ulceration. Here we see that the medial cuneiform is really what's driving the ulceration formation. That's really where that wound was under that medial cuneiform. And so I know that I'm going to kind of follow that super construct idea, even though, again, whether it's a Charcot or not, and involve some of those joints beyond just that area of concern. So that's going to include the talonavicular joint. I also think the subtalar joint, is part of this. I think that in retrospect, because again, this was done, it may have been 2 years ago now, time flies. that I'm trying to make sure that I can lift that medial cuneiform and get that up off the ground, because that's, again, what was driving his ulcer formation. At the time, I didn't put in any lateral column fixation. And I think, again, now I tend to lean more towards going ahead and placing, a 7.0 screw across the CC joint, trying to elevate that cuboid, because I do think that drives a lot of deformity in these patients. Again, this one was a little bit different because it wasn't kind of the classic Charcot reconstruction per se.
So
that's kind of my thought process.
For those listening, there's a long intramedullary nail through the midfoot, basically a beaming construct. Intramedullary nail down the first ray through the head. You dorsiflex the hallux, you throw the wire down the medial column after you've kind of prepped and corrected, and place the beam down the medullary canal, the first metatarsal, all the way up through TMT, NC, TN, and then throw the cross-locking screw. So your goal is to reestablish the midfoot and try to stabilize and keep it there. And you also did a subtalar joint fusion as well. Mm-hmm. I think there's a lot to think about here in terms of what you should do and whether it turns out to be the correct thing to do or not. I think we've all gotten ourselves into situations where you plan, you do something, and it doesn't turn out to be quite the right thing. You fuse X and Y, and then Z fails. And then you think, well, I should have fused X, Y, and Z. Or, you understand my point. It's hard to predict what's going to happen with these people. So I think being proactive here, I don't do a lot of this surgery. I'm not the expert on any of this stuff. But stabilizing the hindfoot construct with the subtalar joint fusion, and then, like you said, put in some fixation in the lateral column just to kind of stabilize everything, because whatever you don't stabilize is going to be the linchpin, the point that could go to failure. What do you think, Leland?
Yeah, no, I think it looks great. I think, especially if it achieved the goal of getting this patient ulcer-free and ambulatory, because I think that's something that we overlook a lot when doing Charcot surgery, assuming this is a Charcot, is the ultimate goal, again, of getting this patient ambulatory without an ulcer, even if you're using some type of brace, which I think is acceptable as well, too. So I think, I think how was the soft tissue? I mean, when doing this kind of surgery, even medially, there looked like a lot of soft tissue to dissect through, because I'm assuming you didn't do this through a minimal incision approach, right?
No, correct. This was, I did that medial incision, and it definitely was. It was a lot of soft tissue to work through. Mm-hmm. I was very concerned, actually, for him with healing afterwards, right? He was somebody I watched really closely with that incision. Luckily, he healed it. Like I said, I actually saw him just recently, and he's remained, ulcer free. But again, I think it's this construct. I do really like this beaming technique, this intramedullary fixation. What I don't like, and I think this is something that's actually being addressed in some of the newer versions of this device that are coming out, is that cross-locking screw through the talus doesn't make you feel really warm and fuzzy. It is so small. It's a singular screw. But so far, for those that I've done, that screw's been able to hold up. But I'd like to see in the future some of those, the future devices with a second screw, another cross-locker that's more kind of in that midfoot, hindfoot area. But, plate fixation on the medial side of the foot, though, those large, Charcot recon plates can also be challenging with the soft tissue, though, and trying to get coverage over those.
Yeah. And in this particular construct, I think, you mentioned the lateral column, but I think it's most important to do what you did in terms of fusing the subtalar joint. I don't think you can put a medial beam without fusing the subtalar joint. I think it's just going to be doomed to fail.
Agreed.
In terms of the lateral column, I don't. It seemed like you had relatively good height of the cuboid and adequate alignment of those, the lateral column. I don't think I probably wouldn't have done that either.
Yeah, it's hit or miss, right? It's some of them I look at and I think it looks okay, and that's not the location of the kind of main point of their deformity, and then others you think, oh, I wish I would have just gone ahead and put something across there, but So far, so good. I think when you do any kind of reconstructions like this, you have to know that you're going to get to the end and you're going to look at your x-rays, and it's still not going to look like a quote unquote normal foot, right? Like that's not the goal. The goal is to get the ulceration healed, try to make it as plantigrade as you can. But if you start to get your little angle measurements out on your PAC system, things still aren't going to be quite where they belong.
I totally agree. I saw a patient of mine he'll be 4 years post-op this July, and slowly over the years, it was a similar thing. It was a medial column fusion, and I actually put in a 3D printed navicular too.
Awesome.
Yeah, and it looked radiographically perfect on the first 6 months, and then it slowly lost a little correction. And then a screw broke, and then it was dormant and fine for, I see him like every 4 to 6 months. We take re-x-rays, and like I look at the x-rays and there's certain things that I just drive me crazy. But again, you look at the patient holistically and he's still walking and there's no ulcer and he's doing fine, right? So you're like, it requires every ounce of restraint not to go in there and remove things and try to revise things. But again, just looking at the long-term goal of keeping these patients ulcer-free and ambulatory is what's most important.
Yeah, absolutely. You'll always be your own biggest critic too when you're looking at your post-op x-rays. Like, it is so hard. I feel like, I don't know, there's probably never a surgery that I do that I get to at the end and I'm just like, everything about that is perfect. I wouldn't change a thing. Like most things I could have gone just a little bit further. I could have done this. But that's, it's part of the process.
But Jeff loves trauma. They come in broken and he gets to put them back together.
I know. He does. He loves it. So what that last case told me is that after 12 years of marriage, Jeff is still not listening when I talk. And I told him what the conditions were for that patient's history. So that's what I learned from this part of our podcast.
I'm not commenting on that.
If I haven't started listening after 12 years, I don't see that changing.
Yeah.
So
I'm just going to have to live with that.
These patients are very difficult. I agree with you guys. So if you can reconstruct it, keep them, well, most of the time they don't have pain because they're neuropathic, but if you can keep them ulcer-free, plantigrade foot, ambulatory, I don't really care what it looks like on the inside because you're not going to win a beauty prize. You're not going to win any, you're not entering this x-ray in for, top prize in the county fair. We're not trying to win anything here. That is a win if they stay ambulatory and ulcer free. So those are so hard. I don't like doing those cases. I typically, Ashley, I typically don't do those cases. I send them to someone smarter and better at surgery than I am. So I can handle trauma. I can put people back together, but these are so complicated. They're complicated patients, right? It's a complicated foot attached to a complicated human. There's usually a reason the foot looks like that. And if you get an x-ray and it looks like that and the human seems normal, then get some more lab work because that is not a normal appearance of a foot per se. So they're very complicated.
I think on those like true Charcot diabetic patients now, my threshold to just recommending the patient have a TTC fusion with a nail has been going down because I don't think earlier on I appreciated as much of the rear foot that was driving that midfoot deformity. I mean, I think intuitively I understood it, and I lengthened my gastrosoleal complex thinking that was enough. But I think long-term stability with those midfoot Charcots with a TTC nail is probably the best, I think.
Yeah, absolutely.
They don't tend to be svelte either. They're usually sturdy people with putting a lot of pressure down through there. So you have to keep that in mind too. They're usually not like a 75-year-old little old lady with, osteoporotic bone. Like these are big people putting a lot of stress through there. So you have to kind of figure out, okay, is my construct strong enough to overcome the amount of pressure that's going to be pushing down on this with or without bone healing? Because you assume the bone is going to heal. Most of the time it does, but sometimes it doesn't. Then you're relying on the construct, and if the construct isn't sturdy enough to counteract that, that's when things are going to break. And we've all had things break. I mean, that's just the nature of doing enough surgery is things will break. Bone won't heal and things will break. So you kind of try to counteract that. And the longer you've been out doing surgery, you try to like counteract that. You're like, okay, well, if that, then then this might happen. So then I'll do this. so that, like you just end up second guessing yourself sometimes, but looks good. So
I think that's why people love doing surgery on pediatrics, because no matter what you do, they heal.
Yeah.
I don't get to do a whole lot of peds,
Yeah.
but I've had a few. And I remember this one case, and I don't do a lot of pediatric reconstructive surgery, but I had a pediatric patient that had a pretty robust, pretty big osteochondroma underneath and the entire nail bed was distorted. And we did surgery on it. And post-op week 1, this I think the patient was probably in first or second grade, and she just ran all over, abused the foot, and there was. The wound was dehisced. I'm pretty sure it probably went down to the distal phalanx, the incision, and I was freaking out. My mentality is, my probe de bone in my 70-year-old diabetic smoking patients, and sure enough, 1 week on I don't know, amoxicillin elixir, and the patient was completely healed next week. So it was amazing. God, I got to stick to peds.
The magic of kids.
Everything.
Yeah.
Did I ever tell you that I played in a band when we were in residency? Did I ever tell you this, Leland?
No. What'd you play? What instrument?
And our name, I played the drums horribly. Self-taught, never had a lesson. Can carry a beat, but no drum fills. But I came up with a name, and we called ourselves Probe to Bone, because we were an all podiatry band. So we were Probe to Bone.
Nice.
Never had a gig.
Any recordings?
No. Just a basement jam session. Just getting together, basement jam, and Probe to Bone.
Right. I played my first live event last year at
really?
fundraiser, which was a lot of fun.
Was it? You do cover songs? What are you doing?
Yeah, we covered a couple songs.
Yeah, nice. That's fun.
Yeah, but one of my colleagues that I work with at Scholl College, in a previous life, she was a pop singer from the Philippines. So she's a professional.
No kidding.
Singer. Yeah.
That's cool.
That's awesome.
Yeah. So we had vocals to drown out any of the poor instrumentation that was happening.
That's fun. All right. Well, Ashley, thank you for joining us.
Sure.
A couple of interesting cases there. So I think it's cool for people to see you guys teach at the school, but now each of you have kind of gone through a couple interesting cases. So yes, you teach at the school. Yes, you do all the academics. Yes, you teach lectures. Yes, you do meetings and all that stuff, but you're also taking call, going and rounding, doing surgery, seeing patients in clinic. So it's the full gamut of stuff that you guys do. So thanks for coming on and showing us some of the things that you've done recently.
Great cases.
Well, thanks. Thanks for having me on as your second choice backup option. Happy to fill that role.
We call you B-list.
A little bit.
B-list. Okay.
You're on the B-list.
Yeah. Appreciate that.
We got an A-list, but you're the only one on the B-list, so you just get called in. You're the bullpen. Something. You're the bullpen arm. Okay. Starter got food poisoning. We're calling in the bullpen. We don't want the long reliever.
You might want to stop.
Right. Yeah.
It's not getting better. All right. Thanks, everybody, for joining us on this episode of Paw Patrol featuring Dr. Ashley Dikis. This is your host, Dr. Jeff Dikis, and
Dr. Leland Jaffe.
We'll see you guys next time.
Take care.